If you are over 60, please listen carefully. Some routine medical tests can do more harm than good when they are ordered automatically. Not because doctors are bad, not because medicine is useless, but because one small abnormal result can start a chain reaction that older adults are rarely warned about. First comes the test, then the follow-up scan, then the biopsy, then the procedure, then the complication. And by the time it is over, the person who walked into the clinic feeling fine is now dealing with a medical problem they never had before. Doctors call this a medical cascade. Most patients call it, "I wish someone had warned me." Today, I'm going to show you 5 tests I would question after 60 and the exact words I would use before saying yes. Because after 60, the goal is not to avoid medical care. The goal is to avoid unnecessary harm. And the most important question is not always, can this test find something? The better question is, what happens if it does? Let's start with number 5. Number 5, routine PSA testing after age 70 in low-risk men. PSA is a blood test used to screen for prostate cancer. Now, let me be very clear. Prostate cancer is real. PSA testing can be useful for some men. If you have symptoms, a strong family history, previous prostate problems, or your doctor is following something specific, this conversation may be different. But for men over 70 who have no symptoms, no strong family history, and no previous prostate concerns, routine PSA testing is not as simple as many people think. Here is the problem. PSA can find prostate cancers that grow very slowly. Some of these cancers may never cause symptoms during a man's lifetime. But once the number comes back abnormal, the worry begins. Then comes repeat blood work, then maybe an MRI, then maybe a biopsy, then maybe treatment. And treatment can come with side effects that affect urination, sexual function, energy, and quality of life. So the question is not, can the PSA test find something? Of course it can. The question is, if it finds something, will treating it actually help me live longer or better? That is the part many men are never told clearly. Imagine a 72-year-old man who feels fine. He is active, he walks every morning, he has no urinary symptoms and no family history of prostate cancer. He gets a routine PSA because it was added to the blood work. The number is a little high. Now he is nervous. Another test is ordered, then imaging, then a biopsy. The biopsy finds a very slow-growing cancer. Now he has a new label, cancer patient. Even if the doctor recommends watching it, the man may live with anxiety every day. If treatment is recommended, he may face side effects from treating something that may never have harmed him. That does not mean PSA testing is wrong for everyone. It means you should not accept it automatically without understanding the next step. Before saying yes, ask your doctor, at my age and with my health history, what would we do if this result came back high? Then ask, would this test change my treatment, or would it only start a chain of more testing? That one question can completely change the conversation. Because if the answer is, we probably would not treat aggressively anyway, then you deserve to know that before the first test is done. Number 4, routine cardiac stress testing when you have no symptoms. This one sounds very responsible. You are over 60, and someone says, let's just check your heart. That sounds safe. It sounds smart. It sounds like prevention. And sometimes it is. If you have chest pain, shortness of breath with activity, unexplained fatigue, known heart disease, fainting, or a concerning exam, a stress test can be very important. But if you feel fine, have no symptoms, and the only reason for the test is your age, you should slow down and ask questions. A cardiac stress test usually measures how your heart responds to exercise or medication. Sometimes you walk on a treadmill. Sometimes medication is used to stress the heart. Sometimes imaging is added. The test can be useful when there is a reason, but in low-risk people without symptoms, stress tests can produce false alarms. And false alarms in medicine are not harmless. A small abnormal result may lead to another scan. That scan may lead to a cardiology referral. That referral may lead to a catheterization. And a catheterization is not just another test. It is an invasive procedure. It can involve bleeding, kidney strain from contrast dye, artery injury, and anxiety. In older adults, even small complications can lead to big setbacks. The heart is important. Nobody is questioning that. But for many older adults, the biggest heart health benefits often come from the basics: blood pressure control, cholesterol management when appropriate, walking, strength, sleep, blood sugar, not smoking, taking prescribed medications correctly. Those things are not flashy, but they save lives. So before accepting a routine stress test when you have no symptoms, ask, what symptom or risk factor are we testing because of? If the answer is only you are older, ask, would the result change what we do, or would we still focus on blood pressure, cholesterol, exercise, and lifestyle? That is not being difficult. That is being informed. A good doctor should welcome that question. Number 3, carotid artery ultrasound when you have no stroke symptoms. The carotid arteries are the large blood vessels in your neck that carry blood to your brain. A carotid ultrasound checks for narrowing or plaque in those arteries. At first, this test sounds like common sense. Find a blockage before it causes a stroke. Who would not want that? But this is where medical testing gets tricky. If you have had a stroke, a mini stroke, sudden weakness, speech trouble, temporary vision loss, or neurologic symptoms, this test may be very appropriate. That is not what I'm talking about. I'm talking about routine screening when you have no symptoms at all. In that situation, the test can find narrowing that may never have caused a problem. But once it is found, it can lead to more scans, more specialist visits, more worry, and sometimes even procedures. And procedures on the arteries of the neck are serious decisions. So again, the question is not, can the test find something? The question is, will finding it improve my life more than good medical management would? For many older adults, the best stroke prevention is not hunting for silent plaque. It is controlling blood pressure, treating diabetes, managing cholesterol, staying active, avoiding smoking, taking the right medications when they are truly needed. Before saying yes to a carotid ultrasound, ask, have I had symptoms that make this necessary? Then ask, if this shows mild or moderate narrowing, what exactly would we do next? If the answer is, we would probably just watch it, then ask whether the test is truly needed right now. Now, I want to be clear. Stroke symptoms are different. Sudden face drooping, arm weakness, speech trouble, sudden vision loss, sudden severe neurologic changes. Those need urgent medical care. That is not routine screening. That is an emergency. Number 2, colonoscopy after 75 if you are low risk and had normal previous screenings. Colon cancer screening saves lives. I want to say that clearly. For many adults, colonoscopy is an important tool. It can find polyps before they become cancer. It can also investigate symptoms like bleeding, unexplained weight loss, anemia, or major bowel changes. But after 75, routine colonoscopy becomes an individual decision. That means your age alone is not the only factor. Your overall health matters. Your previous colonoscopy results matter. Your family history matters. Your ability to tolerate the procedure matters. Your willingness to go through treatment matters. The reason is simple. A colonoscopy is not just the camera. There is bowel preparation, which can cause dehydration or electrolyte problems in some older adults. There is sedation. There is a small risk of bleeding. There is a small risk of perforation. There is recovery time. And if something is found, there may be more procedures. For a very healthy 76-year-old with previous polyps, continuing screening may make sense. For an 82-year-old with several medical conditions and multiple previous normal colonoscopies, the benefit may be much smaller. That is why the conversation matters. Before scheduling a routine colonoscopy after 75, ask, based on my previous results, what is my actual risk? Then ask, are there safer options for me, like a stool-based test? And ask the most honest question. If this test found cancer, would I be healthy enough and willing to go through surgery, chemotherapy, or other treatment? That question can feel uncomfortable, but it matters because screening only makes sense if the next steps make sense too. If you would not want or could not safely tolerate the treatment that follows, then the screening decision needs to be handled carefully. Again, I am not telling you to avoid colonoscopy. I am telling you not to treat it like an automatic checkbox forever. Number 1. Bone density testing that automatically turns into long-term medication without a real discussion. This one needs precision. A bone density test, often called a DEXA scan, can be useful. Falls and fractures can be devastating in older adults. A hip fracture can change independence, mobility, and quality of life very quickly. So I am not saying bone density testing is bad. The problem is the automatic pipeline. You get a scan, the result shows low bone density or osteopenia, then suddenly you are on medication. Then the medication continues, year after year, and nobody clearly explains your actual fracture risk, your treatment timeline, your side effects, or when the medication should be reviewed. Some osteoporosis medications are very helpful for the right person, but no medication should be automatic forever. With certain bone medications, long-term use can rarely be linked with serious problems, including unusual thigh bone fractures or jaw complications. These risks are uncommon, but they are serious enough that you deserve a real discussion. So before starting bone medication after a scan, ask, is this osteoporosis or osteopenia? Then ask, what is my actual fracture risk? Then ask, how long do you expect me to take this medication and when will we reassess? And finally ask, what should I do besides medication? Because bone health is not only about a pill, it is also about strength training, balance, protein intake, vitamin D if needed, vision checks, safe shoes, fall prevention, and making the home safer. A medication may be part of the plan, but it should not be the whole plan without discussion. Now here's the bigger lesson. The most dangerous medical test is not always the test itself. It is the test that nobody explained. It is the test where nobody told you what happens if the result is slightly abnormal. It is the test that starts a chain reaction before you even understand the first step. So here are the 5 questions I want you to remember. Question 1, what are we looking for? Question 2, what happens if the result is abnormal? Question 3, would this test change my treatment? Question 4, what are the risks for someone my age? Question 5, is there a simpler or safer option? These questions are not rude. They are not anti-doctor. They are exactly the kind of questions an informed patient should ask. A good doctor should welcome them. Because the goal is not to avoid medical care. The goal is to avoid unnecessary harm. The goal is to protect your independence. The goal is to make sure every test you accept has a real purpose. If you are over 60, do not be afraid of medical tests, but do not accept every routine test automatically either. Ask what it is for. Ask what happens next. Ask whether it will actually help you live longer, stronger, or better. That one habit can change the quality of your medical care. If this video helped you, subscribe to Dr. Robert Senior Health for simple, practical health guidance for older adults. And before your next appointment, save these 5 questions. They may be more important than the test itself. This video is for educational purposes only and does not replace medical advice. Always speak with your own doctor before changing your screening plan, medication, or treatment.